And welcome to this PrecisCa breast mini tumor board on breast cancer. My name is Dr. Reshma Matani, and I'm a breast medical oncologist and an associate professor of medicine at Sylvester Cancer Center, University of Miami, where I co-lead the breast cancer program. It's my good fortune today to be joined by several well-renowned experts in breast cancer, who I will now ask to introduce themselves. Dr. Buchholz.
Hi, my name is Tom Buchholz. I'm a radiation oncologist, professor emeritus at MD Anderson Cancer Center in Houston. I'm the medical director of Scripps MD Anderson Center in San Diego.
Terry Bauman is a breast surgical oncologist. I direct the breast cancer program at the Orlando Health Cancer Institute.
Hi, Bill Gradisher, professor of medicine and chief of HEMONC at Northwestern University in Chicago.
Hi, I'm Maxine Jockelson. I'm a breast imager at Memorial Sloan Kettering Cancer Center, professor of radiology, and I also do a little bit of PET.
This is an 83-year-old woman who presents with an irregular plaque-like area on her right nipple areolar complex, for which punch biopsy demonstrates an invasive ductal carcinoma, grade 2, ER positive, HER2 negative. She undergoes mastectomy, sentinel lymph node biopsy, a 4.4 centimeter focus of grade 3 invasive ductal carcinoma with associated intermediate grade ductal carcinoma in situ is noted. 3 of 3 positive sentinel nodes with the largest metastatic focus measuring 1.4 centimeters. So she initially presented with a 6 millimeter area of ulceration at her right nipple, and she has a poor performance status with an ECOG of 2, multiple comorbidities shown, including hypertension, hyperlipidemia, type 2 diabetes, reflux, hypothyroidism, and chronic kidney disease. She's gravida 7, para 6, no exogenous hormone exposure, had an oophorectomy in the past for a benign tumor, consumes 7 drinks per week, but no drug or tobacco use, and has a family history and 2 sisters having breast cancer, but no history of ovarian or colon cancer in the family. So the nipple area is, the area of ulceration at the nipple is biopsied and shows grade 2 invasive ductal carcinoma, ER positive, HER2 negative. A mammogram and ultrasound confirms this asymmetry, measuring 2.5 centimeters in the right breast at the site of a previously biopsied carcinoma. And an MRI reveals skin thickening associated with the known malignancy, as well as an additional area of non-mass enhancement in the right lower outer quadrant spanning 4.6 centimeters. There is imaging that's done, including a CT of the chest and a bone scan, which is negative for any evidence of metastatic disease, and her Oncotype comes back very high at 45. Dr. Jockelson?
Sure. So this is a single slice from an axillary MRI, subtraction images, and you can see an area of enhancement going along the skin surface. I don't see the actual nipple here. I'm not sure exactly where this is, but I think this is kind of in the more inferior breast. And then there's also an area of non-mass enhancement extending posterior to this area in the lateral breast. Then and then just one point, it's interesting that they did a chest CT and a bone scan. Ideally, at least chest and abdomen should have been done. I mean, since this was a fairly big tumor, if you're going to stage the patient, then ideally it should be a PET scan. The NCCN guidelines have actually recently changed so that you can actually do a PET at the same time as a diagnostic CT instead of doing the CT and bone scan first. So ideally, it would be a PET, but if there were no PET, chest and abdomen at least for somebody like this.
Thanks. She undergoes a mastectomy and sentinel lymph node biopsy, 4.4 centimeters of grade 3 invasive ductal carcinoma, ER positive, PR negative, HER2 negative, associated intermediate grade DCIS, evidence of Paget's disease of the nipple. She meets with medical and radiation oncology for further recommendations. And given her age and comorbidities, the risk of toxicity from chemotherapy is considered to be quite high. The CARG BC score is a risk tool to predict grade 3 to 5 chemotherapy toxicity in older patients, and it would seem to indicate that she would have a tough time with chemotherapy. There are additional surgical recommendations given the 3 out of 3 positive sentinel nodes to complete an axillary dissection, which she does indeed go on to complete, showing 6 out of 15 positive nodes, total 8 macrometastatic areas, largest 1.7 centimeters, and 1 micrometastasis. There's extranodal extension, and there are plans for radiation to the right chest wall and axilla. So questions in terms of this older patient with significant comorbidities and ECOG performance status of 2, significant nodal disease post-mastectomy and axillary lymph node dissection. Dr. Jockelson, we have this patient who has a family history. She has 2 sisters with breast cancer. We don't know if she had a germline mutation in BRCA2 or any other gene, but with the information we had, I'll ask if you would have put her through an MRI. I'll just remind you she was 83 years old.
So the one place where people often agree that MRI is useful is in women with Paget's disease if they don't have any obvious disease on mammography, because we know that there is often associated disease with Paget's, that if you don't see it on mammogram and ultrasound, I think in terms of treating the local disease, you really would like to have that MRI to just get an idea as to whether or not she needs a mastectomy, because just because she has Paget's doesn't mean she needs one, but you do often see additional disease. So in terms of her local management, the MRI, I mean, I don't have the mammograms, but it seems like she had a lot more disease anyway, in which case it may not have been of value. But for Paget's in general, MRI is actually a good way of looking for additional disease just for the local treatment. I certainly don't think that every 83-year-old who presents with breast cancer needs one for sure, but I do think in this setting, it was probably of value to at least know what to do locally.
Mm-hmm. And from a local standpoint, a local therapy standpoint, the decisions for radiation to the chest wall and axilla seem pretty straightforward, but I'll ask both Dr. Mamanis and Buchholz to comment on anything further that could perhaps be highlighted in this 83-year-old with a right-sided tumor. Dr. Buchholz, do you want to start?
Yes, I think as long as her performance status is adequate, that post-mastectomy radiation is warranted based on the disease characteristics. I'm not clear if the nipple ulceration was a true cancer ulceration representing really T4 disease, but she could potentially have T4N1 breast cancer, stage 3 disease. Clearly, radiation will reduce the risk of local regional recurrence and inappropriately would target the chest wall, the draining lymphatics. I would treat also the internal mammary lymph nodes, and then the level 3 axilla, because she has had a completion dissection in the supraclavicular fossa. She should be able to tolerate these treatments relatively well. We would just obviously continue to monitor her carefully, but in general, radiation treatment, she should be able to get through with acceptable short-term and long-term risks.
Dr. Mamanis, from a surgical standpoint?
I don't have any additional comments. I mean, I think a mastectomy is appropriate in this patient, and she already eventually had an axillary dissection. She's 8 positive nodes, obviously, but there was an adequate dissection. The only other comment I will make is that for patients with Paget's disease, and if indeed we do an MRI and there's no additional evidence of disease in the breast, we offer those patients also a central lumpectomy, where preserves most of the breast mount, obviously followed by breast radiotherapy. So that's another option that we have offered to patients that have tumors either right behind the nipple or involving the nipple with no other evidence of disease.
Great. And then lastly, I'll ask Dr. Gradishar, how do you deal with these types of situations? Is this a patient, given her age and comorbidities, that you would just place on hormonal therapy and hope for the best, or would you be willing to think outside of the box and offer something like adjuvant capecitabine in an 83-year-old? What are your thoughts about that Oncotype of 45?
I'm not sure the Oncotype would have been something I would have ordered. I mean, by all appearances, as Tom pointed out, the patient appeared to have locally advanced breast cancer. And I think the fundamental decision is this 83-year-old with a truckload of other comorbidities going to be someone that can tolerate any form of systemic therapy. And that's even before you got to the tool that tells you, you know, she's going to have problems potentially in a big way if you give her chemotherapy, including a pretty high risk of hospitalization. So with all that as sort of a preamble, you know, of course, we got to look at the patient. But there were also data that have been looked at in the past. Hymus published a paper years ago from the CLGB looking at capecitabine versus more standard chemotherapy regimens in this older patient population, and capecitabine was clearly inferior. So I think that you really have to come down to the issue of, are you going to, you know, bite the bullet and treat this patient? And if you're not, because of your concern with comorbidities, then I would try to optimize your endocrine therapy. And this, as opposed to maybe some of our earlier discussions, this might be a patient where you could justify or at least make the case for considering a CDK4/6 inhibitor added to endocrine therapy.
Okay, so unless anyone has any last comments on this case, I'll summarize. So the panel concludes the recommendations given her history of Paget's is to consider MRI, radiation targeting chest wall and draining lymphatics, IMN, and level 3 nodes, supraclavicular fossa, in terms of systemic therapy, optimizing hormonal therapy, and a discussion on the CDK4/6 inhibitor.